So bundle payments are back in the news right now because, as you know, we had mandatory cabbage bundle several years ago. It was withdrawn, and now we went to BPCI Advanced, which was voluntary, and under the guise that if there wasn't a lot of uptake, and I don't know how many people are in BPCI for bundle payments here for cabbage. Probably nobody. I did a deep dive. Oh, you can't. I'm sorry. BPCI for the voluntary bundles, we did a deep dive. I did a deep dive at the Cleveland Clinic. We didn't participate because they were not structured very well. So because there wasn't a lot of uptake, the HHS announced, Secretary Azar announced a couple weeks ago they're going to be mandatory bundles again. So I just want to instill the fear of God in you with this presentation because it's coming. Remember, Medicare, this is all because of Medicare. It's 3 years old right now. Lyndon Johnson, great social reform, was perfect. And what happened was that we didn't have a real good control on how we were going to contain costs throughout that whole thing. And you saw these slides from me before, and it's exponential, and that prediction came true. Although the curve has come down a little bit, it's not necessarily where it is at the top, but it's pretty close. And basically, the government is here. You know, they've decided that you got to stop taking money from my back pocket, right? So we're going to try and reform the healthcare payment system. So we had a couple things that happened, important legislation in the last 10 years, the Affordable Care Act and MACRA, which you all know about, and those were designed at controlling costs. Title III. When I was there, we wrote a lot of Title III before it went into legislation, and so it was good stuff. It's the stuff that the VCSQI does all the time, you know, controlling costs, you know, improving care and reducing costs and complications. And the triple aim is here. I mean, we hear this all the time. We want to have better care, better health, and lower costs, of course. But the reality is that payment methodologies are changing. There's value, not volume, that we're talking about here. There's consumer engagement. You all know that with patient experience. There are risk models, and there are going to be winners and losers. And flexibility and adaptability are really the keystones to what if you're going to succeed in this environment or not. So deflators of costs. How do we move costs around? So we have high-performance networks, and we might think that we are one because we're improving quality, reducing costs, lowering complications. So we're a high-performance network, but we're really talking about it from a payer perspective, our COEs, which they think are high-performance networks where you can do those things, not in an organization like this, but in a different organization. And that's us. Benefit design, you all feel this, you know this, your patients tell you this all the time. We're talking about narrow networks. As you're paying for health care, you're getting narrower and narrower in terms of what you're going to reimburse. I'm speaking from a payer perspective. And there's increased deductibles and premiums. And basically, this is what's happening to the consumer. You know that with these narrow networks and the deductibles, it's getting out of control. You could have $5,000 deductibles in the course of a year, and that's pretty hard for an average family to sustain. And then there's increased risk for providers, and that's why we're talking about this. This is an interesting graph because as you start out, the payment continuum, when we're fee-for-service all the way to the left, to us, it's low risk. To the payer, it's higher risk. So for the provider, it's minimal risk, but as we get into pay-for-performance, which is the middle bars, the middle section, we're taking on more risk because we're being held accountable for our performance. And then now we're into capitation, but we're really not capitation, we're into bundles. And bundles are here where provider insurance risk is really high at this point, and the payer risk is minimal because we're moving into a world where the payers are saying, okay, we can only take so much from deductibles and from patients, and we're going to now put it on the providers to save money in this situation, and we're going to put you at insurance risk for that. So MACRA was important legislation for us because it brought forward the quality payment program, and you have two arms, the alternative payment models and MIPS. So MIPS is basically this fee for service, and you're managing penalties. It's a rob Peter to pay Paul. It's a budget neutral situation. So you basically perform, and if you don't perform well, then you get a penalty and somebody else will get a benefit, a bonus. APMs, alternative payment models, are different because you're starting to manage risk, and that's what we're talking about in terms of bundle payments. So where we really want to be and where we're going right now is category 3A and B. So alternative payment models 3A, it's all upside. So there's gain, but there's no risk. And that's Medicare Shared Saving Program, Track 1. And now we're moving into Track 2, and it's Category 3, where there's downside risk, but the upside risk is higher. So with the Category 3B payment plan, and these are bundles, this is why we're talking about this right now, bundles will bring you into that. So alternative payment models in Category 3A, they're developed in partnership with us. We've designed them, we've helped them, and there's additional benefits on the upside, but they're smaller. There's no downside risk in an alternative payment model. 3B, the advanced alternative payment models, which are the bundles we're going to talk about, there is downside risk. And so you can get, just by participating in an advanced alternative payment model, you can get a 5% upside lump sum incentive, and then your annual benefit or your annual fee schedules increased if you're part of an advanced alternative payment model. So this is, if you're not in an APM, you're in MIPS. If you're in an APM, you still have MIPS adjustments plus the APM specific awards, but when you're in an advanced alternative payment model, which are the bundles that we're going to talk about, you get a 5% lump sum bonus, and then if you're a qualifying participant, you can get higher annual adjustments. So again, to summarize it, if you're a qualified practitioner, then you will get a higher physician fee schedule update, a 5% lump sum bonus, and you're excluded from MIPS, which is all good. And so these are the current advanced alternative payment models. There, unfortunately, were not a lot for cardiac surgeons, but the mandatory CABG bundle will be considered an advanced alternative payment model, the one that's going to be coming out now. So bundle payments. What is bundling? It's a market strategy where you take all Part A and Part B payments and put them into a single unit, and you pay for it collectively. So you don't pay the physicians differently than or separately from the hospitals. And this is a graphic of that. In the past, a traditional fee for service, we're paying each of those components on the left, but in bundling, you pull them all together and you pay for a comprehensive coordinated intervention or an episode, if you would. So what are the benefits? Consumers, you can plan your costs, right? I can, because I know what my deductible is, and I don't have to have a fee-for-service deductible that keeps increasing until it reaches my maximum. Insurers and employers can plan their expenses. Hospitals can optimize cost accounting, and physicians, we start thinking about relationship with our hospital and all the things that we've been doing here in the VCSQI for years. So do they decrease costs? There's reasonable data and evidence that in joint replacement bundle payments, as sponsored by CMS, reduced costs. And did they affect quality? Yeah, they also affected quality. So there's a lot of energy, if I should say so, at CMS to promote the bundling of payments, because they feel like, first of all, CMS doesn't want to be an insurer anymore. They want to be a payer. And that was managed Medicare, MA plans, Medicare Advantage. When I was there at CMS and under the Bush administration, they basically said, we don't want to be an insurer anymore. We just want to write a check. So why don't we do managed Medicare Advantage? We'll just pay, United to manage our patients for us, and we'll just, write the historical check. So we don't have to go through all the pre-authorization. We don't have to go through all those fee schedules. We don't have to do anything that we've always done traditionally. So In a bundle, though, a bundle's not a bundle is not a bundle. So the key pressure points for bundles are design. So Alan and I designed a bundle for this organization in 2003 and got it accepted by Secretary Thompson. And you have to define your anchor procedure. So for our bundle, it was the cabbage. Then you have to figure out the diagnosis codes that are in it, the target services, the complications. Are you going to, what is the pre and post-op window? So is it 3 days before? Is it 30 days before? Is it 3 months afterwards? Is it 90 days afterwards? So then you have to decide on inclusion criteria and exclusion criteria. The problem with the BPCI bundles is that they were totally exclusionary bundles, and the only thing they excluded was readmission for cancer and admission for trauma. Everything else was included. So if you had a woman that you did a coronary artery bypass on or a valve on, and she had breast cancer, was undergoing chemotherapy, Alan or I or any other cardiac surgeon in this room those costs would be attributable to us, and it had nothing to do with the procedure. So the inclusionary bundles are much better, and I've been working with, 2 years now with CMS to define inclusionary criteria for cabbage and PCI, and PCI after STEMI. So the attributable costs, that's where I am on I'm the chair of the MACRA Committee on Cardiovascular Care. Some of the issues that we have to deal with are open concurrent episodes. So if you, like I said, have breast cancer and you're going in for a cabbage, how do you handle all those payments that are going towards your additional chemotherapy or the treatments for your breast cancer? And then you have to decide on prospective versus retrospective reconciliation, prospective pricing. So we were very much ahead of the curve here. We were talking about prospective pricing. So we looked at all of the data in Virginia. We said this is what it would cost, and we included post-acute care. We included it 3 days beforehand and 30 days afterhand, including post-acute care. And we said, okay, this is our prospective price for a coronary artery bypass bundle. What the BPCI and what I don't know what it's going to be next, is going to be retrospective reconciliation. So you provide the care, you get paid fee for service like you normally do, and then they do retrospective reconciliation. So they go back and they look at all the bills and they say, oh, by the way, you exceeded your costs, and you had no way of knowing during the course of treatment whether you were heading in the wrong direction or not. So that's retrospective reconciliation. We have a bundler tool in Cleveland. We use this. I've been working on bundles there in the private sector and the commercial side to look at all those things that we just talked about, how you develop a bundle engine and then get to an eventual pricing and reporting mechanism. So we use this to customize bundles that we do with particular payers, and then we use it to price the bundle. And then we look at the cost and the utilization within the bundle, and we track that over time. So I'm going to go through this quick, the steps to determine it, because it's very complicated. I guess what I want to impress on you is that bundles are very complicated. They're not very simple. And you have to be very careful as you wade into this new world of bundle payments. So you have to determine the bundle episode and DRGs, and this is what we do. We go through all the DRGs. We say what's in, what's out. We have to determine excluded conditions. So these are exclusions like active cancer, renal dialysis. When you come in, a transplant, AIDS, end-stage renal disease, you're excluded from the bundle. You determine the time period. So we looked at what are our attributable costs in the 0 to 90 days prior to a cabbage, the cabbage admission, and then 30 to 90 days afterwards. And then we design it based around where we see we have control over what we can do and what we're attributable for in terms of the delivery of that care to that patient. So for instance, you're having a coronary artery bypass operation 90 days before you've had a traumatic episode and you were in the emergency room. Is it fair to attribute that? You're shaking your head no, and I agree. But in the current the way they're designing these bundles, like everything's included. So you have to be careful about your pre-window and your post-window. And then you have to really analyze the data and determine the routine care for that pre- and post-operative period. So we look at everything. We say, okay, a stress test seems like it fits into a coronary artery bypass operation, right? Pulmonary function test, the cardiac imaging, a duplex vein mapping. That's all. This is an inclusionary model. So these are the things that you go through and you say, those are reasonable things that we order as physicians, clinicians, when we're going ahead and going to operate on a patient. And the post-operative stuff, we have to decide, is a post-operative transfusion okay? Is it ER treatment? Yeah, it is okay, but what if you get hit by a car? Is the ER treatment for getting hit by a car okay? No, not really. If you go back to the operating room or ER because you have a sternal wound infection, that's okay. So you develop all these different codes and revenue codes that you can apply in the inclusion. And you look at the complications of the postoperative period and what is it that we want to be attributable for. So I worked on the macro committee. So if you're an elderly person who had a cabbage and developed a pneumonia 75 days post-op, is that attributable to the cabbage? Probably not. So then you have to decide, all right, so a pneumonia is good for about 7 days. Probably attributable to your admission into your treatment in the hospital, but not good for 70 days because that's probably related to patient's disease. So you have to go through all of this and decide, what revenue codes you're going to include in your postoperative care. And then you utilize the bundle modeler, as we said. You select the bundle, you identify the anchors, you gather the claims, and then you finalize the bundle. And then you come to the last step is pricing. So how do you price this? Well, you have to look at what you've done historically, and once you develop it and the methodology, you look back over several years. For instance, I did this with BPCI for the clinic for cabbage, and what the pricing that they were putting out for us for coronary artery bypass grafting was errant. It was wrong. They had outsourced it to somebody else. They came up with the wrong data. I looked at all of the data over a 3-year period, and it wasn't consistent, so we decided not to participate in the voluntary bundle for cabbage because of that. And you have to look at, and we did this, and Ellen and I, there he is, when we did our bundle, we talked about first dollar protection and second dollar protection. So how do you determine, what is an outlier? So when you hit the case hits an outlier total spend, the bundle gets shattered. So we agree, you're my payer, and I'm doing a cabbage on a patient that you're insuring, and I say, well, this is a very complicated patient. I'm going to do the best I can, but if it's 2 standard deviations away from the mean for cost, it's going to shatter the bundle, and I'm going to go to fee for service. So those are the agreements you have to have up front when you start doing these things. Or second dollar protection, where you can hit an outlier threshold and the bundle remains, but then the threshold beyond that are fee for service. So you can say, all right, give me the bundle, but if it's 2 standard deviations away from that, I'll get paid fee for service for all those days and other things that we're doing for that patient. So in the BPCI Advanced, it was a voluntary model. It was a retrospective bundle payment with a 90-day clinical episode, which was pretty dangerous. It had 29 inpatient episodes, of which we deal with a lot of them, valves and cabbage. 8 of them were cardiac related, and the payment was tied to performance on quality measures, and those were all done. It qualified as an advanced APM. The preliminary target prices were very troublesome to me because it was total cost of care pricing, which I alluded to already. So it was everything that happened to that patient from March 1st until September 30th, irrespective of whether it was related to their coronary artery bypass operation. So it was a total cost of care with limited exclusions that I already identified. And there was not an inclusionary model, and there was no attribution modeling. So it was pretty dangerous because you're basically going at risk for everything that has happened to that patient. And essentially, it's a population health model. where you say if it's 30 days before and 90 days after, now you got 120 days. So you're taking care of that patient for 120 days, and you're responsible for every episode that happens to that patient in those 120 days. These were the things that were in BPCI Advanced. The quality measures were reasonable. But really, honestly, all-cause readmission and advanced care plans were pretty soft. It was a real soft landing. So the CABG 30-day mortality, we're used to doing it. But excess days in acute care after an AMI, that's a little bit troublesome too, because you could have a hip fracture, you have an AMI, and then you're attributed all the care for that patient afterwards. It was historical pricing over 3 years. Data acquisition was outsourced and was done poorly. And they came back and they said, oh, by the way, we made a mistake and we were kidding. We're going to give you the new data. Within like 7 days, you had to make up your mind. It was all-inclusive, as I said, and there was a lack of an attribution model. So it was very low. We had none for cardiac. We did go into COPD. Mayo went into heart failure, and Methodist in Houston went into heart failure, but it was very low adoption across the country. So the mandatory CABG was withdrawn. The voluntary BPCI Advanced was put forward. There was low adoption. And then Secretary Azar says, guess what? They're coming back. They're going to be mandatory bundles, and we're going to design them, and you'll just have to live with them. So really, for next steps, understand the concept and structure of bundles. Like I said, a bundle is not a bundle is not a bundle. Design is everything. Commercial payers are going to follow CMS very quickly. As soon as CMS comes out with these bundles, you can be darn sure that commercial payers within 6 months are going to be giving you the same pricing. It may not be the exact dollar amount, but it's going to be the reduction in the pricing or the bundling concept altogether. And basically, you have to restructure your service line and get, align its goals between clinicians and hospitals, because this is a reality. It's coming real hard, real fast, and you ought to be prepared for it. So care pathway development will be critical. Supply chain decisions, I know we live with that. I know particularly the cardiologist, Robert Shore, probably lives with it more, and picking a pacemaker, picking an ICD, a defibrillator. You have to get involved with those supply chain decisions in order to make reasonable decisions. And then you have to share the P&L statements with physicians, because we can't figure out how to help the hospitals or how we can work together to make this financially viable for all of us going forward unless we understand your profit and loss statements. And so you need leadership committees that do that. We do that. I do that. I help other hospitals develop those so that they can understand their P&L statements. They get involved in supply chain decisions, and that's about it. I think it's a brave new world that we're all going to be reaching pretty soon. I'm not sure what the bundles will be. I'm sure they're going to involve cardiac somewhere, somehow, whether it's going to be interventional cardiology or cardiac surgery, but the design's going to be very interesting. I hope that the work that I've been doing with MACRA, with the attribution models, will play into this, and that it won't be a total cost of care model where there are very limited exclusions, because if there are limited exclusions and it's total cost of care, it's going to be very, very difficult for any of us to win in this world. So, any questions?
When do you think we would expect to see this? Like, is it next year? Is it 5 years? Is it?
Oh, it's going to be soon. It's not going to be 5 years. It'll be within a year. You said 1 year? I would say within a year for sure. What will happen is it'll go through the rulemaking process, or it'll go out as a proposed rule by the end. By the inpatient prospective payment system rule just came out. So I would say a year from today, you'll have all of these bundles in that rule and finalized. So I would say take the proposed rules very seriously when you see these things, and make sure that it works and it fits for your institution. And what you're seeing in the proposed rule, we would respond to those comments in the proposed rule before we made the final rule, but generally 80% of what you see there is going to be in the rule, and so you got to prepare yourself, in terms of going forward and making sure that you're ready with your service line. to adopt these bundles, because it won't be voluntary anymore. It's going to be mandatory. And as I said, commercial payers are going to come along real quickly. Ellen, your thoughts?
No, you covered a lot of ground pretty quickly, and it's a little overwhelming. When you and I have lived it since 2004, but the take-home message is bundling is here. It's going to be, the mandatory word is the word, and we have to dust off in future meetings sort of what are the lessons we learned over this last decade and a half, and where the pitfalls are, because there's still, for the cardiologists, the administrators, the surgeons, you know, it's a bottomless pit, particularly now when you include in what has changed from before is that 90 days pre-intervention and the up to 90 days after. That's an extraordinary length of time to take over and be accountable for the care of an individual that is getting cardiac intervention, whether it is catheter delivery or surgical intervention, particularly since a third may have congestive heart failure. So I think that this is, I'll be interested to see, while I recognize that it's, Azer said, it's mandatory, operationalizing this, just like operationalize the APM in general, has been a challenge. And so how this is going to be done to that level of scrutiny and accuracy is, I think, of concern.
I think one of the advantages we have as an organization is that we have our clinical financial tool. So, you know, you can share that with the physicians and the clinicians and administrators can sit down and look at that and see where the pressure points are, like where you can, what buckets, where you can improve your efficiency and all that. And doing continuous improvement, we have a whole team of engineers that I send out into hospitals that do continuous improvement, and they go into the operating room, they go get into the cath lab, into the EP lab, and they look at the workflow and the stream of it, and we look at the number of personnel that are involved in an operation, the time it takes, wheels in, wheels out, the turnaround times. And so looking at your efficiencies are going to be incredible, because you're not going to work very well just in reducing pricing for devices, right? You can only go so far and go so low in terms of paying for a valve. What you're going to have to do is the human resources to deliver the care and the efficiency which those human beings work in order to deliver that care. So it'll be interesting. It's going to be a very brave new world for everybody. But I think we're well prepared with our clinical financial tool.